So last time we were talking about anthracyclines and anthracene. We mentioned that anthracyclines, they include 4 drugs: doxorubicin, daunorubicin, epirubicin, and idarubicin. For doxorubicin, it is also known as adriamycin, which is the first trade name for the drug. And sometimes in protocols, they abbreviate it as A. So, and sometimes it is referred to as H, which is hydroxydaunorubicin. So you can see that doxorubicin is a hydroxylated daunorubicin. So it's sometimes referred to as hydroxydaunorubicin. It is a major component in some protocols like CHOP, in non-Hodgkin's lymphoma. So C is cyclophosphamide, H is hydroxydaunorubicin, O is the trade name for vincristine, and P is prednisolone. And in fact, a common protocol in Hodgkin's lymphoma is ABVD, which is A is for adriamycin, which is the trade name for doxorubicin. B is for bleomycin. V is for vinblastine, not vincristine, and D is for dacarbazine. Dacarbazine is, as we mentioned, is like a non-classical alkylating agent or a methylating agent. We mentioned that all drugs, they have the potential to cause cumulatively cardiac toxicity, acute or chronic. So acute has, cumulatively is through chronic use, but acutely, any drug could cause this potential of acute toxicity, which could be manifested as changes in ECG changes, or reduction in ejection fraction, or a syndrome called pericarditis myocarditis syndrome. While chronic toxicity is reported when the patients exceed a certain cumulative dose lifelong. Like, as we mentioned, you have to count or keep in mind or estimate or add up all the doses the patients received from anthracyclines through the patient's life. Okay, so cardiac toxicity is reported, for example, for doxorubicin, let's say, at 550 milligrams per meter square cumulatively, or if a pediatric patient exceeds 300 milligrams per meter square. Of course, like, those numbers differ from one reference to the other. Now, you can exceed that if you co-administer an antidote for the cardiac toxicity, which is dextrazoxane. Cardiac toxicity is usually formed by the generation of free radicals, by the interaction of anthracyclines with iron that is found in the cardiac muscles, which is rich in cardiac muscles. So dextrazoxane is an iron chelating agent that binds to iron and inhibits the interaction or prevents the interaction of anthracyclines and the iron. Now, this risk is increased if the patient is receiving drugs which cause cardiac toxicity, like cyclophosphamide or another anthracycline, or the patient is receiving HER2 neo-targeting therapies like trastuzumab or pertuzumab, or the patient received radiation to the heart through like chest radiation, if it is a breast cancer or lung cancer, or even, let's say, lymphoma in the upper region or the chest area. Now, there is a late onset of cardiac toxicity that could happen years after finishing therapy. This is like more expected with children. It is 3 to 10 times fold, and would be associated. So it is more expected in children. The children also has more expected arrhythmias, and also you could expect sudden death in children exposed to anthracyclines during their childhood. Epirubicin is another anthracycline, and it is used in breast cancer, given fast IV bolus to reduce the risk of extravasation. cumulative dose that, if exceeded, will increase the risk of cardiotoxicity is 900 milligrams per meter square, and side effects are similar to doxorubicin. Valrubicin is a semi-synthetic analog of doxorubicin, but it is not given systemically. It's given directly into the bladder, installed into the bladder in an administration technique called intravesicular administration to reduce its systemic absorption and systemic toxicities. Side effects include local irritation of the bladder. Mitoxantrone is another drug related to anthracyclines. We mentioned it is an anthracindione. In protocols, it is abbreviated as an N, which is the trade name for mitoxantrone, which is one of the first trade names, which is Noventrone. And it has less potential to cause cardiac toxicity compared to anthracyclines. It causes also nausea, vomiting, and alopecia, and could be combined with RSC for management of AML, or could be combined with other agents for management of castration-resistant prostate cancer, which is prostate cancer that is resistant to androgen ablation, whether it is pharmacologic, like using gonadotropin-releasing hormones, agonists for long periods of times, or like in implants, or for like surgical castration, which is removal of the testes. And also it could be used for management of secondary, progressive, or late stages of multiple sclerosis. Apoptosis are another group of naturally occurring compounds. We have two compounds in this category. We have etoposide. Usually it's not mentioned as etoposide in protocols. It's mentioned as VP16, or might refer to it to its trade name of VP-side. Tinoposide is another agent. It's called VM26, which is the most popular name in protocols for tinoposide. You'll have to remember abbreviations of all the drugs. It's used for pediatric leukemias, small cell lung cancer, testicular cancers, Hodgkin's lymphoma, large cell lymphomas, which is a variant of non-Hodgkin's lymphoma. And as we have mentioned, anthracyclines cause topoisomerase 2 inhibitors, as well as ipopodiphyllotoxins, while irinotecan and topotecan, which are the camptothecins, they inhibit topoisomerase 1. And later on, we mentioned that DNA single-strand or double-strand breaks are expected. The cells fail to repair that DNA break, and then the cells will undergo apoptosis because of active cell cycle checkpoints. Resistance is mediated through pumping of the drug outside of the cells using active efflux transporters like P-glycoproteins, or changes or mutations or reduction in expression of the target, which is topoisomerase 2. So the cell would depend on topoisomerase 1 in like relieving supercoiled DNA, or a cell cycle checkpoint regulator, which is P53, would be mutant or deleted. And this is in fact seen in so many cancers. And here the cell would fail to undergo apoptosis following the damage that was caused by the drugs. The drug is given orally or IV. It is given as slow IV because of the toxicity related to the excipients of the drug, like or solubilizing agents that are found in the formulation. Adverse effects include leukopenia. Effect would peak, or the nadir is 10 to 14 days, and recovery is within 3 weeks. Thrombocytopenia is also a side effect, nausea, vomiting, stomatitis and diarrhea, alopecia, and hepatic toxicity. Another side effect is secondary leukemias or secondary malignancy. So if a patient is treated for any type of cancer, he could develop a secondary malignancy of the type of AML later on. Now, AML in those patients, like secondary to epopedophilotoxins therapy, would have certain characteristics. First of all, it is associated with mutations of a gene called MLL, or mixed lineage leukemia. Leukemia would appear earlier compared to alkylating agent induced AML or secondary malignancies. So etoposide or epopedophilotoxins appear within 1 to 3 years, while like secondary to alkylating agents would appear later on, like after 5 to 7 years. For AML in patients with alkylating agents, it is preceded by a transitional state called myelodysplastic syndrome. But here we don't see a myelodysplastic syndrome transformation. And with etoposide, if you exceed 2,000 milligrams per meter square, you will have a higher risk of development of secondary malignancies. Tiripeside is the other agent. Co-administration of anticonvulsants could lead to increased metabolism. Dosage need to be not to be reduced in patients with impaired renal function. It's used in refractory ALL. Refractory means ALL that is not responsive to therapy, or you didn't encounter or notice any initial improvement or response after initial therapy. You could add it to cytarabine. In that setting, side effects include myelosuppression and nausea and vomiting. Now, also we have miscellaneous drugs, or drugs with different mechanisms of action. One of them is bleomycin. Although bleomycin is known to be an anti-tumor antibiotic, which mediates DNA intercalation, but also it has multiple other mechanisms. So bleomycin is a mixture of bleomycin A2 and B2, which is a copper chelating peptides. Bleomycin is activated upon exposure to iron that is found in tissue, and generates a superoxide or free radical generating moieties, which would lead to DNA cleavage or RNA cleavage or damage, or lipid damage. So this is like the overall mechanism of action. So it affects cells, as you can see, like it affects DNA damage or DNA and RNA. It could be an SG2 phase specific agent. Now, the drug bleomycin is mainly metabolized by an enzyme called bleomycin hydrolase. And bleomycin hydrolase levels are very low in skin and the lungs. That's why bleomycin's signature side effect is skin toxicities and lung toxicities. Resistance could develop if the cancer expresses high levels of the inactivating enzymes or bleomycin hydroxylase, reduced uptake of the drug, repair of strand break or increased mechanisms of repair, and inactivation of the free radicals that are generated from bleomycin by the free radical scavenging moieties like thiol or thiol-rich proteins. The drug could be given IV, IM, sub-Q, or intravesicular directly into the bladder. And the dose should be reduced in reduced renal function. As we have mentioned, the drug causes skin toxicities and pulmonary toxicity. Pulmonary toxicity is expected if you exceed a cumulative dose of 250 milligrams or 400 milligrams per meter square. In some other references, you would see that. Or the patient is elderly, or he has received chest radiation. Like there are multiple risks for the pulmonary toxicity. Some of them are mentioned here, and some are not. The adverse effects include myelosuppression, skin toxicities, as we have mentioned. You could reduce that by co-administration of corticosteroids. We have also hyperthermia, headache, nausea and vomiting, peculiar acute fulminant reactions, include profound hyperthermia, hypotension, and sustained cardiorespiratory collapse, especially in patients with lymphomas. Um, it's not a classical anaphylactic reaction, but it could be related to release of endogenous pyrogens when cancer cells are killed by bleomycin. But as we mentioned, the most common side effect is pulmonary toxicity, and it has a wide range of manifestations. 1% of patients who develop this pulmonary toxicity could die, and it develops in 5 to 10% of patients receiving bleomycin. Mostly happens with patients who exceed 250 milligrams of dose cumulatively, or if he receives a single dose of 30 milligrams per meter square. For elderly, for potential to, if there is a potential for the drug to accumulate, like reduced renal function, if the patient has underlying pulmonary disease or received chest radiation, or if the patient receives high oxygen concentrations during anesthesia or respiratory therapy of previous uses. A treatment is mostly symptomatic or supportive for those patients. Corticosteroids could be administered if they were administered immediately after inflammatory changes have been detected with bleomycin administration. Mitomycin is another agent. Its main mechanism of action is generation of bifunctional or trifunctional alkylating agents. We know a reminder of the mechanism. It could potentiate radiation therapy effects, could induce teratogenicity or carcinogenicity in rodents also. Its use is limited, so it is only used for anal cancers or for superficial transitional cell carcinoma of the bladder or renal cell carcinoma or transitional cell carcinoma of the bladder, let's say. So it is, as you can see, it has limited toxicity. Resistance could be mediated through reduction of the activation of the drug to the functional alkylating agents, or increased breakdown of the drug, or reduction of the intracellular levels by activation of efflux mechanisms. As we have mentioned, it's used for anal cancers or transitional cell carcinoma of bladders. In eye surgeries, خصوصا is surgeries that involve the cornea, like LASIK surgeries. So they administer mitomycin at the scar, in fact, on the eye, to prevent formation of scar tissue and impairment of vision. So mitomycin is used in LASIK surgeries to prevent formation of scar tissue that would impair the vision. Adverse effects include myelosuppression with probability of extension of effect, especially if you receive mitomycin cumulatively, nausea, vomiting, diarrhea, stomatitis, rash, fever, malaise. If you exceed 50 milligrams per meter square dose acutely, you have some side effects like hemolysis, neurological abnormalities, interstitial pneumonia, glomerular damage. And if you exceed the 70 milligram per meter square, you will have more renal damage. And if this develops, you have to discontinue the drug immediately, and also pulmonary fibrosis. Higher doses could cause congestive heart failure, like higher than 30 milligrams per meter square. And it could also potentiate toxicity of other cardiotoxic agents like doxorubicin. Methoxytane is a compound related to the herbicide or pesticide called DDT. If you remember, DDT was used as a herbicide, and the problem of that, it is concentrated in the fatty tissue, and it is released slowly from there, so it could poison people who consume like cattle that have been fed grass fed like or with DDT on it. So DDT مبيد للاعشاب، يعني كانت هاي قضيه كبيره بالنسبه للدي دي تي، انه كمان الدي دي تي is a carcinogen, not only يعني a toxic compound. So methane is specifically used for adrenal cortex carcinoma. Now for adrenal cortex carcinoma, if you reduce the activity of adrenal cortex cells, especially if you give spironolactone, you will slow down the replication of cells or like proliferation rate of cells, and they will be less responsive to methoxytane. So you have to know that you cannot give both drugs concomitantly. So for the absorption, distribution, metabolism, elimination, you have to know that this drug has similar feature to DDT. It is concentrated in fat and slowly released from that site. So this would keep its level high for a sustained period of time. Adverse effects include anorexia, nausea in most of the patients, somnolence and lethargy in about 34% of patients, dermatitis, and when you destroy the adrenal cortex, you have to replace the adrenal cortex hormones, which are mineralocorticoids and glucocorticoids. You have to keep that in mind, of course. Trapectidine is a relatively new drug. It was extracted from a marine invertebrate called tunicate. It's like a sea sponge or something like that. So يعني as I have mentioned before, this should draw your attention to مثلا sources or places where we have like maybe some life forms or special life forms زي كائنات البحر الميت مثلا, or lake creatures, or living organisms there, سواء bacteria, fungus, or يعني other types of sea life. So this particular drug, in fact, binds to the minor group of DNA and bends the whole structure of the DNA and closes down the major groove. So DNA obviously has a minor groove or فتحة صغيرة للDNA and a major groove. So what happens إنه it binds to the minor groove of DNA and leads to bending of the DNA helix toward the major groove. And this leads to like abnormality in the structure of DNA. It prompts the activation of certain repair mechanisms, nucleotide excision repair, and this would fail, and then we would have like byproducts which are inactive, like double strand breaks, or like this leads to DNA damage. Now, what is special about trapectidine? It doesn't work if you have certain nucleotide excision repair mechanisms that are not present or mutant. Like, for example, there is a protein called XPG. If this is not there, it's a component of nucleotide excision repair, it would not be working. So it doesn't depend on other mechanisms. Like, في mechanism of repair called Fanconi's anemia, or FA, anemia complex. So it works on those cells. The drug could lead to hepatotoxicity, which would be reduced if you co-administer the drug with dexamethasone. It is used to treat liposarcoma or leiomyosarcoma. سرطان بالفاتي تيشو or leiomyosarcoma اللي هو smooth muscle cells carcinoma or سرطان بالsmooth muscles. Experimentally is used for ovarian or pancreatic cancer. Adverse effects زي ما حكينا hepatic toxicity would be increased. That's why they give it with dexamethasone. It causes myelosuppression and destruction of the skeletal muscles in the body, which is called rhabdomyolysis. L-asparaginase, as the name implies, it's an enzyme that breaks down L-asparagine. So L-asparagine is an amino acid. Usually L-asparagine in normal cells is taken either from the circulation, or the cells are capable of conversion of L-aspartate plus ammonia to L-asparagine. So the mechanism of action is that cancer cells, خصوصا leukemia cells, they don't do that. They don't combine L-aspartate with ammonia to produce L-asparagine. So what happens is that you are starving the cells for L-asparagine. You give L-asparaginase systemically, they break down L-asparagine to L-aspartate, and then the L-asparagine will not reach cancer cells. So mainly L-asparagine is used for leukemia, in fact. Resistance is mediated through the activation of formation of L-asparagine in tumor cells. Now, there are some various forms of L-asparagine. We have L-asparagine that is extracted from E. coli. So this is conventional L-asparagine, but L-asparagine is associated with, L-asparaginase is associated with lots of toxicities or antigenicities, let's say, or allergic reactions. So those could be replaced, in fact, by one of, to reduce allergic reactions, you could use one of two things. Either you use the pegylated asparaginase. So pegylated L-asparaginase, the conventional one, is given every day, and this is believed to increase the risk of, in fact, allergic reactions. And on the other hand, PEG asparaginase has polyethylene glycol group of the molecular size of 5,000 5 kilodaltons or 5,000 daltons of monomethoxy polyethylene glycol attached to the asparaginase. And this requires only administration of the drug every 14 days. Or you could use L-asparaginase extracted from bacteria, which is less compared than the conventional L-asparaginase produced or derivatized from E. coli. So the L-asparaginase with reduced allergic reactions is called Erwinia chrysanthemi L-asparaginase. So this has less toxicity, but طبعا this is not mentioned in our textbook. So that's why I have a strike through the text. Now, other adverse effects, antigenicity could lead to one of two things. First, allergic reactions, and second, reduction of the activity of L-asparagine, or development of, or relapse of the disease, or refractory disease, like disease not responsive to therapy. Here, you could differentiate between them by measuring اللي هو circulating antibodies with no allergic reactions. So this one is referred to as silent allergic reactions sometimes. So like antibodies which neutralize L-asparaginase, but without any allergic reaction, but with reduction of activity. Also, L-asparaginase leads to inhibition of protein synthesis of many proteins, like insulin, which could lead to hyperglycemia, or clotting factors, which could lead to clotting factor abnormalities, or lipoprotein productions, which could lead to hypertriglyceridemias, or reduction of the albumin synthesis, which could lead to hypoalbuminemia. So those are expected side effects with L-asparaginase. L-asparaginase also could destroy the pancreas. And if you remember, we mentioned that as type 3 diabetes mellitus, okay, which is related to destruction of the pancreas or pancreatitis. Clotting factors are affected, as we have mentioned, because they are proteins which synthesis is inhibited by L-asparaginase. This could lead to spontaneous thrombosis or hemorrhagic episodes, or like brain hemorrhage. It could lead to brain hemorrhage. It could also lead to suppression of immune function and terminates antitumor activity of MTX, methotrexate, when given shortly after it. Hydroxyurea is another drug. Now, hydroxyurea was a basic drug for management of CML, but with the introduction of newer therapies, they have largely replaced hydroxyurea. So hydroxyurea is also known to induce the formation of gamma globin. As you remember, if you remember, hemoglobin, which is the blood globin, which forms like the oxygen-carrying moiety hemoglobin, like, is composed of 2 alpha subunits and 2 beta subunits. Now, if the alpha subunits, if the beta subunits are abnormally formed, as it is the case with hemoglobinopathies, like thalassemia, in which we have hemoglobin C mutation that lead to abnormal functionality of hemoglobin, or sickle cell anemia, which has hemoglobin S, in which hemoglobin would tend to precipitate or lead to formation of sickle cells. So hydroxyurea, in fact, induces the formation of gamma globin, which would replace the beta globin. So it will produce hemoglobin F instead of hemoglobin A, or adult hemoglobin. So it will produce alpha 2, gamma 2, in fact, hemoglobin or hemoglobin F. So hydroxyurea is used in hemoglobinopathies to induce formation of hemoglobin F that would replace the abnormal adult hemoglobin, which is hemoglobin C or hemoglobin S in case of thalassemia and sickle cell anemia consecutively. Many mechanisms have been reported as like for hydroxyurea as an anti-cancer agent. One of them is the reduction of ribonucleotide reductase, mutation of which would lead to development of resistance. Now, in thalassemia and in fact sickle cell anemia, when hemoglobin, the adult hemoglobin, is abnormal, it tends to precipitate, especially if the patient is exposed to more cyanotic episodes, like exercise or works out. And this leads to precipitation of RBCs, in fact, adhesion to blood vessels, formation of clots, especially at capillaries, and release of intracellular substances from those cells. And this leads to the manifestations of sickle cell anemia and thalassemia. And hydroxyurea, as we have mentioned, would induce hemoglobin gamma globin formation, which would replace the beta globin or lead to formation of hemoglobin F. As we mentioned, in CML, targeted therapy have replaced the use of hydroxyurea, even if the CML cells do not express BCR-ABL, which is the target of imatinib, which is the targeted therapy. We still use interferon for management of CML for BCR-ABL negative or atypical CML. So hydroxyurea is not like an option anymore. في عندنا other hemoglobinopathies like polycythemia vera, myeloid metaplasia, essential thrombocytosis. It is a radiosensitizer, so we combine it with radiation therapy and management of cervical, brain cancers, non-small cell lung cancer, head and neck cancers, and as we have mentioned, hemoglobin S or hemoglobin C diseases or hemoglobinopathies. Many side effects are reported, like leukopenia, anemia, occasional thrombocytosis, or sorry, cytopenia. Upon discontinuation of the drug, those blood elements levels go back to normal. Pneumonitis, GI disturbances, mild dermatological reactions, stomatitis, alopecia, neurological manifestations, increased skin and fingernail pigmentation, painful leg ulcers, especially in elderly or with low renal function, secondary leukemias, and it is a potent teratogen in animals, but in women with child bearing potential, it was not reported to be a teratogen, in fact. Now, maybe one of the earliest theories we mentioned about cancer is that in cancer that we have cells that have rapid proliferation and rapid cells with impaired apoptosis, like those are mechanisms of cell death or like cancer development. Or if the cells, they fail to differentiate. So as you know, if the cells differentiate, they tend to slow down in proliferation. They get specialized or specialized, and this slows down their proliferation. In some cancers, however, differentiation is arrested. One of those cancers are AML. So in AML, especially for early or precursor cell AML or less differentiated AML cells, we could use differentiation inducers. Example of differentiation inducers: vitamin D and its analogs, retinoids, HDAC inhibitors, or DNMT inhibitors. HDAC stands for histone deacetylase inhibitor and DNA-MT methyltransferase inhibitors, and some other cytotoxic agents like, as we will see, arsenic trioxide. Now, ATRA is all trans-retinoic acid. في عندنا also 9-cis retinoic acid could mediate the same effect. So what happens in those with ATRA or all trans-retinoic acid, it is used to restore the differentiation of cells arrested at promyelocytes to normal leukocytes or myelocytes. And this would be associated with reduction of the proliferation of those cells, okay, which is like a signature manifestation of, let's say, leukemia. Now, as you can see, like all the double bonds or the unsaturations of retinoic acid are trans, or like it's called all trans retinoic acid. And it is used, in fact, therapeutically for management of APL. It will induce the differentiation of cells back to normal. So the side effects, one of those side effects is like for management of APL using ATRA or arsenic trioxide is differentiation syndrome. When myelocytes differentiate back to normal, they start infiltration of variable tissues like the brain. So this causes differentiation syndrome. Some, you know, like before it was called as retinoic acid syndrome, but nowadays we know that all differentiating agents would lead to this side effect. So it is called like retinoic acid syndrome, but nowadays it's called differentiation syndrome. Arsenic trioxide is another differentiating agent. So one of the mechanisms that have been reported is induction of differentiation of cells. So it could cause also differentiation syndrome or retinoic acid syndrome. But also, in fact, in cancer cells, since the cell's proliferation is very high, there is also generation of free radicals from the mitochondria. So cancer cells have the free radical scavenging mechanisms are super activated. So if you increase those free radicals more, this would lead to cancer cell death. Okay, So arsenic trioxide first increases the level of reactive oxygen species, which will overload cancer cells that have already overloaded reactive are overloaded with reactive oxygen species, and this leads to destruction of cancer cells using that mechanism. There are other mechanisms, like, for example, it upregulates tumor suppressor mechanisms like Jun kinase, caspases, anti-apoptotic or apoptotic enzymes, P53, and also downregulates anti-apoptotic proteins like BCL2, or inactivates some of the free radical scavenging moieties like thioredoxin or glutathione or other sulfhydryl scavenging proteins. So many mechanisms have been proposed for arsenic trioxide. The drug is given IV continuously until the disease is controlled, or like acute leukemia is controlled. It is it enters into the cells using glucose transporters, metabolized by methylation, and there is no dose reduction in case of hepatic or renal dysfunction. Adverse effects include hyperglycemia, hepatic enzyme elevations, fatigue, dysesthesia, lightheadedness. As we mentioned, patients could have differentiation syndrome, which would infiltrate many tissues, like, for example, the brain, which could lead to mental status changes, the lungs, which would lead to pulmonary effusions or distress. Treatment is symptomatic, like you could give corticosteroids, oxygen therapy, temporary discontinuation of arsenic trioxide, prolongation of QT interval, or you could say torsade. It could happen without co-administration of QT prolonging drugs. Like, if you remember, في عندك some drugs, خصوصا some antiarrhythmic agents class 3, could increase QT prolongation, or enzyme inhibitors like macrolides or imidazoles, or triazoles, like, let's say, antifungal agents. In fact, in case of significantly prolongation of the QT prolongation signal, especially if it exceeds 470 milliseconds, you have to stop therapy, administer potassium also, and then you resume therapy when the ECG changes are normalized. Now, this concludes chapter of cytotoxic agents, but we will have to study the other chapter, اللي هو the table that is the summary of the pathway targeted therapies. I will record it in a bit, inshallah. ويعطيكم ألف عافية إن شاء الله، بالتوفيق.